As we think about sort of new wish things at Christmas time, we think about puppies and dolls and ponies and trains. And when you have a birthday, you think about money and cars and bikes. And when you have an anniversary, it better be sparkly or chocolate or something like that. Well, I'm going to talk about different things in terms of that wish list. And the unmet clinical needs, when we talk about heart team meetings, at least in Rochester, one of the unmet clinical needs is how exactly do we do patient selection? Seems like a mundane thing, not terribly important, except we spend a lot of time with it. You'll remember, of course, the elderly lady from town on whom you did a TAVR on, despite the objections of a colleague who felt she was not symptomatic enough. Results have been nothing short of dramatic. There has been immediate improvement in her dyspnea, after fatigue, and sense of well-being. In fact, she felt so good she became too active too quickly and fell, sustaining a mild compression fracture of her spine. She is undaunted, however, and is recommending a TAVR to all of her friends. So we then talk about patient selection criteria as an unmet clinical need, because there is the issue of frailty versus futility. And we spend a huge amount of time as we see older and older patients. This happens to be one of my patients. I had trained under him and then worked with him. He was a retired physician at the time that I saw him as a patient, hospitalized for respiratory failure, had known severe aortic stenosis. Mean gradient was 41, the aortic valve was 0.83, his ejection fraction was 61%, and had been referred by then his internist for TAVR. He had pulmonary hypertension, he had coronary disease, he had parenchymal lung disease on chronic oxygen, he had steroid use, he had his STS score of 12, his BMI was 22. He had everything sort of going in the wrong direction. You need to remember that old men with low BMI are really old sick men with low BMIs because they haven't had any nutrition. He had progressive shortness of breath. He wasn't able to walk on a block. He was currently in a wheelchair on oxygen, steroid therapy. He was in a skilled nursing home. He had all the other things that would be bad, but then he comes to you and he said, I've known you for a long time, Dr. Holmes. I've got severe aortic stenosis. I've been reading about it. I want a TAVR. I want a TAVR. What are you going to do? You've known him for a long time. He's got severe aortic stenosis. Well, the heart team approach is used. I happen to be the cardiologist. I said, well, what about just palliative care, doctor? Not all that well received. Cardiovascular surgeon said, well, maybe TAVR is okay. And so the heart team decision was to temporize with a balloon valvuloplasty to assess the effect of continued pulmonary rehab. You remember, he's on oxygen, he's had steroids, he's been in the hospital, to see whether he might get better in terms of having had a balloon valvuloplasty. And so we did that. We then said, gosh, this isn't the best thing. This is a temporizing thing. He said, no, I just need to have that TAVR thing. We said, well, this is not the best thing for you. We'll recommend balloon valvuloplasty. And so we had the usual sort of result. It improved the gradient from 40 to 30. And we said to the patient, go back and get well. And get well. And so he got well. He had less exertional dyspnea, had less generalized fatigue. He was off of continuous oxygen. He had tapering steroids for his pulmonary disease. And so he had a transfemoral TAVR. And in October of 2017, I saw him at the end of the year, and he was much improved. He exercises daily, and he said, what have you been waiting for? Why did we screw around with this? Why didn't you just give me the TAVR that I wanted? So what did we learn? We learned that in a very mundane way. This is mundane stuff, but this is actual practice stuff. Balloon valvuloplasty is a reasonable strategy to assess for symptom improvement. Comorbid conditions can affect symptoms out of proportion to aortic stenosis, like he had. Should be treated aggressively before TAVR decisions are made. So that's the first unmet clinical need. It is mundane, but it is real. The second issue is, what are we going to do with low flow, low gradient? Found in 5 or 10% of aortic stenosis patients, There's afterload mismatch, cardiomyopathy. The issues are, is it true, the real deal, severe aortic stenosis, or is it sort of pseudo-severe aortic stenosis, not the real thing? So we know that there are subtypes. Low gradient, if you have an ejection fraction less than 50%, it can be classical low flow, low gradient. Or if it's greater than 50%, it can be paradoxical low flow, low gradient. Or it can be normal flow, low gradient. Not only can we do procedures, and should we do procedures, we need to think about which procedures we should do. And it becomes more complicated because we see those patients that have a preserved ejection fraction, aortic valve area is low, it's indexed to be low, low flow, however. And you have to then be able to understand SVI, terribly important, and that sometimes is not as well understood as it could be. And it can be a mixed bag. It can be a small epiventricular cavity with restricted filling. It can be increased arterial afterload, so you give nitroprusside to it to see what it does. There can be guideline inconsistencies. There can be measurement error in terms of the outflow tract. Mundane but terribly important. Or there can be common valve lesions, because we need to decide whether it's severe aortic stenosis that is critical or whether it's mild aortic stenosis with left ventricular dysfunction. I'll finish then with this case that involves some thinking. We need to be thinkers rather than just doers. 74, patient, Rochester, class 4 heart failure, low flow, low gradient, aortic stenosis, severe functional mitral regurgitation, referred for TAVR. Been referred from another very good institution. He had a history of paroxysmal atrial fibrillation, complete heart block. He had a dual-chambered pacemaker. Didn't have any coronary disease. Ejection fraction was 27%. You can see his SVI was 26. His aortic valve area is 0.7. But he did have severe functional mitral regurgitation. His aortic valve mean systolic gradient was 20, but he was felt to have severe aortic stenosis. So we brought him to the catheterization laboratory, to the echo laboratory, wherever you do those things. For dobutamine, SVI increased to 34, aortic valve area increased to 0.87, mean gradient sort of bumped up a little bit to 26. Fixed, low flow, low gradient, severe aortic stenosis. So you then, as part of the heart team, are going to be asked on Monday morning, or whenever you have that, what are you going to do next? Are you going to say, well, let's go ahead and do TAVR? Maybe you're going to say, well, we're going to do valvuloplasty. We've done that before. Maybe you're going to do CRT. He already has a dual-chambered pacemaker in. His left ventricle is crummy. And he did indeed have an interventricular conduction defect. Or maybe there are other things. And so how are you going to decide that? What are you going to do in a mundane way? In this particular case, the decision was made to say, maybe we should just do CRT. So at 1 month, his New York Heart Association class was 2. At 9 months, his New York Heart Association class was 1. His ejection fraction had gone from 27% to 58% just with CRT. Just with CRT. And his aortic valve area was 1.1. Mean gradient was 32, and he now had trivial mitral regurgitation. So the issue of do we need better tools to evaluate concomitant valve disease is incredibly important, because CRT has been shown to improve mitral regurgitation, normalize LV in selected patients, and in this specific patient it normalized flow and allowed more accurate assessment of the aortic valve, reclassifying it as moderate, not as severe. And so what do we need from a mundane level? Well, we use dobutamine, we use nitroprusside. But from a mundane level, what we need are better ways to think about things, to do the things that we know we can do, but decide when to do those things that we can do. And so our unmet clinical needs are patient selection. How do you assess severity truly? Because we will see patients that have severe disease, moderate disease, and mild disease. We will see patients that have pseudo-severe aortic stenosis, low gradient aortic stenosis, or paradoxical low flow severe aortic stenosis. The mundane needs indeed are mundane. but they make a huge difference to the practice of TAVR going forward. Thank you.